Welcome everyone to today's session. We've got the Health Professionals Research Education Program, Value-Based Approaches to Healthcare and Health Economics. This is an ongoing collaboration that the University of Newcastle Research Advantage Program has with Hunter New England and Central Coast local health districts. For those of you who don't know me, my name is Casey Wilson, and I'm a project officer and a facilitator on the Research Advantage Program. Our program sits in the Office of the Pro-Vice-Chancellor Research and Innovation at the university. For today's session, I ask all participants to mute your microphone and turn off your video throughout the presentations. Today's session is being recorded and we will make it available post-session, provided we have all presenters' approval. I'll remind everyone and invite you all to post your questions in the Zoom chat function throughout the session, and we will hold them over till the end of the presentations, and we do have time in today's program for Q&A. As I begin today, I would like to acknowledge that I'm hosting this online session from the lands of the Awabakal people. I also acknowledge the traditional custodians of the various lands on which we all work from today, and the Aboriginal and Torres Strait Islander people participating in this session. I pay my respects to elders past, present, and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands, sky, and waters of Australia. I'd now like to hand over to Professor John Wiggers, our Director from Hunter New England Research Office and the Hunter New England Local Health District. Thank you, Professor Wiggers.
Thank you, Casey, and thank you for organising this important seminar. I'd like to also acknowledge that we're meeting on Aboriginal lands, wherever we are, and here I am, it's Awabakal lands, and I'd like to pay my respects to Aboriginal elders past, present and future. And each time we have conversations around enhancing research for the benefit of patients and clients of health services, I think we should always be mindful of the particular need to ensure our services are both respectful, appropriate and beneficial for Aboriginal clients, patients and consumers. Today we're talking about value-based healthcare. It's been around for a little bit of time, but not a long time. And I think we've decided it's quite important to have a conversation about what value-based healthcare means and what value-based healthcare research may look like. Obviously, there'll be very many dimensions to value-based healthcare research. And today we'll be focusing, after Professor Francesco Paulucci describes what is value-based healthcare, we'll be talking briefly about a particular approach to value-based healthcare research called variously discrete choice experiments, and a few other titles as well. If I think back in terms of my career in the health service and doing research in the health service, early on, the primary measure of the benefit or the productivity of the health system was often measured in terms of activity. How many patients were seen, what was the length of the wait list queues, what was the waiting time in ET, the proportion of ED patients getting care within a certain time frame. Many of those metrics remain activity-based measures. Subsequent to that, there was an increased focus on the outcomes of care, not just whether people receive care. There was more of a focus on outcomes. And that is, did the care delivered? Did the procedure delivered? Did the admission to hospital produce expected or anticipated outcomes in terms of improvement in patient well-being or care outcomes and health outcomes? More recently, the narrative and the science has evolved to acknowledging that activity remains important, outcomes are important, but there's another dimension which is about the value. We may well be having marked impacts on the health and well-being of individual patients, but it could well be that comes at a cost, a very large cost, which may or may not be sustainable for the health service or health system, and may also not be feasible in the sense of opportunity costs. So in that context, governments, and I can think particularly of New South Wales government, there is increasing scrutiny by the government and particularly Treasury on the value of health programs, health services, health innovations. And there's significant tests being made for any proposals to invest in new treatments, for example, in terms of a variety of different measures, cost benefit, cost effectiveness, et cetera, et cetera. So it's in that context where we in the health service and we health service researchers need to be mindful of the importance of health economic analyses, broadly speaking, and particularly research which addresses the value of any innovations or healthcare programs or treatment modalities. So that is a very brief, high-level summary of why we considered that this was a very useful topic to have in today's seminar. And we've brought together a couple of speakers who are expert in both the field of value-based healthcare and healthcare research, but importantly in the application of some of the research methods of value-based healthcare. And in these seminars, we generally do seek to bring in someone who is an expert in the field, and then we also seek to bring a couple of researchers or clinical researchers to give examples of where the particular topic of research has been applied to the benefit of the researchers, to evidence and knowledge generation, and to service delivery. So today we've got Professor Francesco Paulucci, who's an international expert in value-based healthcare. Is also as an approach as applied through health economics. And he'll give us a brief introduction to the global and the local landscape of value-based approaches to healthcare and economics. Francesco will be followed by a presentation by one of his postdoctoral research fellows, Dr. Laura Wall, who will give us an introduction to one powerful tool that we can use to investigate the first level of value-based healthcare, understanding the preferences of patients and providers. Laura has worked with this tool and using discrete choice experimental designs for a number of years within the health setting and on projects with our two speakers today. We'll also have a presentation by Professor Balog and also Dr. Nick Zankowski, two clinicians who have undertaken discrete choice experiment type research and applied it in their particular clinical domains. Joel will be presenting via video today in the seminar live, and Nick will be has set us a recorded presentation. So I'd now like to introduce Francesco Paulucci. I'd like to say Francesco, who is a friend of mine, and welcome him to this particular seminar and invite him to educate us on what is value-based healthcare. Welcome and thanks, Francesco.
Thank you, John. I hope everybody hears me okay. Also, thanks Casey and Joe Dixon, who's not here with us, and thank you all for coming. I really liked the picture, which was clearly pre-COVID, I should say. So thanks for that. I will share my screen and have this conversation around a topic that I'm very passionate about. Obviously, when we talk about value-based healthcare and health economics evaluation, what we do you see the screen?
We can see it, Francesco, but it just needs to be in presentation mode.
All right, beautiful. That was my concern. All right.
Thanks.
So when we talk about this very important topic, obviously, we need to also make a reference to the work that it's done through the Value in Health Economics and Policy Network-based year, which brings together really clinicians, health professionals of all kinds and really of all environments, from the local communities to the other states and really international practitioners with a variety of backgrounds to try and think really hard about what is the meaning of value. So clearly here we take a particular approach, and Laura and I have been collaborating with Zolt, Nick and others to try and make it valuable, in fact, for the health services and the decision makers. So what do we mean by value-based healthcare? Basically, this is a concept that has been introduced by Porter quite a while ago, as John mentioned, and Porter is an American, very famous contributor, I would say, in many aspects of the thinking around healthcare systems organization, more broadly speaking. And basically what this concept does, at least from an economics or an economist perspective, is it flips a little bit the paradigm and the coin of what we always have thought about value and evaluation in particular. So instead of having cost over quality, so measure the incremental cost effectiveness ratios, we want to think about how to achieve greater value for patients and, in fact, all the stakeholders involved, not only to improve the goals of, let's say, efficient healthcare delivery, but also to try and embed maximization of health outcomes per dollar spent. If we do that systemically or at a multi-level approach by capturing the information that really as an important element the experience of patients or other stakeholders, then we can move towards a more holistic approach to value. Now, this concept has been adopted and incorporated in many policy documents, even in strategic pieces of work that are present almost in all our state governments. In New South Wales, this is what value-based healthcare is referred to. It doesn't differ very much, and it clearly refers to a paradigm shift, if you want, with a much larger focus on patients that we have ever had before in terms of their experience, their value, if you want. In fact, even the choice of words, sometimes for an economist, when you see wellness, it's such a broad term that we need to break it down, if you want, and think about how we can operationalize it. I would say that in the New South Wales approach to value-based healthcare, the most important, I would say, focus is on the word experience and sustainability. So clearly, the cost effectiveness or cost benefit, as John referred to, is underlying decision making more and more so, and this will probably be sort of the leading theme in discussions in the years to come. Nevertheless, it's important to find an approach that also takes into account the experience in receiving care and providing it. So obviously, here there are some references that you might want to look at what our government has in mind when thinking of value-based healthcare. What is it that we do with that concept in our work here and in our Value Health Economics and Policy international network? Well, we try to help, of course, clinician practices, professionals, clearly in healthcare, but the methodologies are applicable to any sort of value-based sustainability question. And what we try to do is try to understand, firstly, from a qualitative perspective, what are the dimensions that really do matter for the stakeholders involved. You can think of individual patients, who are clearly the ultimate recipient of care and the ones on which we measure outcomes. With that exercise, which is of a qualitative nature, we then try to build a quantitative based tool that aims at eliciting preferences of these stakeholders. And obviously, we combine that by looking at the other levels that matter here, so the service and the system level, to then understanding what these choices mean in terms of use of resources. And that would mean also determining how optimal we can be in that allocation of resources. And also at a more decision policymaker level, we can try to connect those multi-criteria decision, in fact, level type of analysis that whether we like it or not, or if it's done in an ad hoc manner or not, it's definitely driven by multiple factors. So we try to disentangle, to sort of unpack them at the various levels and try to have an holistic sort of approach that is preference based. Now, just 1 minute before I pass the ball to Laura, we'll go in details. You can, of course, find us here, and we are here also to sort of convey the very simple message that we are open to help you in try to bring value to what you already are doing in a very valuable manner. So thank you for having me, Laura. I'll stop sharing. You can continue. Thank you.
Thank you, Francesco, and welcome, Laura. So Laura, as I've been indicated earlier, is a postdoctoral research fellow with Newcastle Business School and is an expert in the conduct of discrete choice and preference studies. Welcome, Laura.
Thanks, John, and thanks, Francesco. Casey, if you could just start my slides. So as you can see from what Francesco's described so far, value-based healthcare as a whole approach is quite complex, and there's a lot of different levels. And there's kind of that preference elicitation, finding out what matters to people stage, and then there's those economic evaluations. So the economic evaluation side of things has kind of previously been covered in one of these series by Penny last year. So I won't be talking about that. I'll be looking at that first level, which is finding out what matters to people, what matters to patients, but also clinicians and other stakeholders. And this is important, obviously, because it's kind of one of those core tenets of value-based healthcare. But there is also evidence to suggest that incorporating people's preferences and having this more patient-centered approach not only improves patient experience and satisfaction, but leads to higher rates of completion of treatment, adherence, and can also lead to better sort of health outcomes themselves. So if we want to know what matters to people, how do we do that? So there are a variety of qualitative methods like interviews and focus groups where we can have these discussions and kind of scope out the space of the possible things that might matter to people. And that's really valuable. And there are people who do that really well. We then kind of need to take that information and sort of, funnel that into finding out more specifically and also a bit more objectively and sort of quantitatively, really specifically, what are these key factors that matter? And also, what are the trade-offs that people make between those? So we know that the things that we say matter to us don't always reflect our choices. I might say that I really care about the environment, but I don't always dispose of my rubbish in the most optimal manner. And that's because there's all these other factors that I'm trading off between when I'm making those decisions. And so this is where looking at choices that we make is a really helpful way to find out how we balance those trade-offs. The most ideal way would be to go out and sort of just observe what choices people actually make in the real world, but for a variety of reasons, that's not always possible. And so the next best option is to kind of create these hypothetical scenarios that reflect the real world choices and ask people questions to make those hypothetical decisions. And that's essentially what a discrete choice experiment does. And that's what I'll be talking about today. Next slide. So a nice simple way of thinking about what a discrete choice experiment is it's basically like that game, Would You Rather? So I described these. There's plenty of options online for different would you rather scenarios. And you can see that kind of critically what they do is they give us two different factors. Maybe it's the situation of kind of where you're going to be and how long it might take that you're in that situation, or the role that you're in. We get these two different factors, and then there's a particular kind of level of each of those factors, and we're trading off between them. Do we want to be in jail or in a coma? And the jail is for 5 years, or the coma is for a decade. So just click again, Casey. In a DCE, it's the same kind of thing, but a little bit more serious. And so one of the DCEs that we're doing at the moment in our group is looking at vaccine hesitancy around COVID vaccinations. And there's a whole host of factors that people might be sort of trading off between when making a decision to get vaccinated or when choosing which vaccination they want. So it could be maybe the side effects and efficacy might be 2 factors, or choosing some more time-related factors, how long it will last before they need a booster, or how long the development process was. That's something that a lot of the vaccine hesitant community talks about with COVID. And then there's also kind of these more external factors that also might be playing into people's decisions around the implications around getting a vaccination. So these more sort of policy-related things. So there's a whole number of different factors that could be contributing to someone's decision. And we want to be able to know which of those factors are most important to people and which of those are going to influence their decisions. Next slide. And so in each of those examples there, each question was just trading off between 2 factors, but really a discrete choice experiment puts all those together in the one scenario. And this is why discrete choice experiments, or DCEs, are sort of the preferred tool in finding this out, because they're very flexible. You can put in as many factors as kind of possible for somebody to comprehend. And you can tailor the factors to really answer the key question that you're interested in. And so, this here is a little mock-up of what that discrete choice experiment on the vaccinations is looking like at the moment. And you can see that people get presented with typically 2 options. You can have 3, you can have 1, but 2 is the most standard. And there's a number of different sort of features. We refer to them as attributes in those decisions. And we simply ask people, which of these 2 scenarios would you prefer? Which is the better scenario from your perspective? And then one of the really neat things about DCEs is that you can add on this extra question at the end about, would you actually use this? Would you actually go and get this vaccination? And this gives us really useful information about things like people's willingness to pay for a service, people's willingness to use a service, and we can get all sorts of useful kind of predicted utilization that we can then feed into economic models and stuff like that. People will be presented with a number of these different choice sets in a discrete choice experiment. So you'll give them multiple different scenarios, which are all similar, but different in slightly key ways. And that's how we then use that data and model it to find out which of those factors are most contributing to people's decisions. Next slide. So I've kind of mentioned already some of the benefits, that they're really flexible, but quite comprehensive. And because they're putting in these kind of forcing people to trade off, they're also less prone to bias. And so a tool that you're all probably very familiar with is the Likert scale, where we ask people, how important is factor A to you? How important is factor B? And people sort of have a tendency when reporting in this manner to say that everything is important. But we know that in reality, we have to make those decisions and we have to kind of make a choice. And so DCEs are a really nice way of taking that information into a bit more of a realistic framework, how we actually make decisions in the real world. They're also quite useful because they give us multiple different types of information. So we can get that rating information, information like, say, the duration is sort of this amount of important, and efficacy is this amount of important. And then from that, you can provide kind of rank information that duration is more important than efficacy and so on. And then you also can do this really neat thing where you can provide an equivalence. And so you can say that, for example, 1 extra month for a booster is equivalent to, is exactly the same level of importance as a drop in efficacy of 10%. And this kind of statements that you get can be really useful for decision making, and also incorporating into these other later models to find out kind of what you need to say change to reach a critical threshold of, say, 70% vaccination. And so you can use the output from DCEs to estimate these levels of value, these levels of importance, and put it into those things like economic models, or you can just then take that data and use that to improve your design or your policy so that it includes the features that matter to patients the most. Next slide. with good things always comes something bad. Because of this comprehensive, flexible nature, they can sometimes be a bit complex. And so you need to, if you're going to be using something like a discrete choice experiment, you really need to think about the cognitive burden that you're putting on people and only include the factors that are really important and aren't going to be too overwhelming for people to make these decisions multiple times. And like all research, if they're not set up properly, they can sometimes confirm the biases that we have. So if we have these preconceived ideas about what we think is important and we put those into the DCE, then we're only getting information about that. So it's really important that you have an evidence-based process leading up to the discrete choice experiment to define what factors you actually include. And the other downside is that they can be a bit costly. So because you want to have this really nice long process beforehand, if you don't already have that done, if you're sort of starting from scratch, then that can take a little bit of time, and time is money. There are also some stages of the discrete choice experiment that you really do need sort of specific expertise for, the particular construction of the choice sets and the analysis. And so those are the things that you need to consider if you're wanting to do these. Do you have the time and the team? But this does vary a lot between projects, and there are some projects that might actually be very small, feasible, and can be done quite cheaply, and others that are very long and complex and expensive. So there's no hard and fast rule, but these are the things that you need to think about. Next slide. So I kind of touched on this a little bit. Like I said, they're very flexible. You can use them for a whole host of reasons. So we might want to just find out what matters to people so that we can design services that include those factors that are important. We might want to improve our economic evaluations, or we might want to just understand patient decision-making better from a sort of more research perspective, just kind of finding out some more about the way that people process information. And so you can use these DCs across a whole host of settings. Next slide. So I mentioned that they can be a bit involved if you need to kind of start from scratch. The sort of standard recommended process is that you go through your standard developing a clear research question, that you use things like systematic reviews, focus groups, interviews, other surveys to really make sure that the attributes that you're selecting are the appropriate attributes to include. You then need to kind of construct the actual choice sets, which involves some experimental design work. You need to consider things like how the scenario is framed, which Nick will talk about a little bit. Then there's obviously things like data collection. You want to do some pre-testing and pilot testing. So if you want to do these things properly, there are a number of steps. But like I mentioned before, these things can vary largely between projects. So if you are interested and you want to know more what it might look like for your question, then just get in contact with Francesco and I, and we can have a chat with you sort of one-on-one about that. Next slide. And just to finish up, thought I might give you a very brief rundown of some of the different projects that we're currently doing in our group that's using discrete choice experiments. So there's that vaccine hesitancy one, which uses a DCE. There's one looking at people's preferences to join clinical trials of surgery that involve a sham procedure, which is what Zolt will be talking to you about. There's a project that we're doing with John, which uses a very similar tool called best-worst scaling to look at the barriers to implementing sort of routine provision of antenatal care in regards to weight gain. And then we'll sort of shortly be starting on a new project that recently got funded, which is looking at kind of optimal telehealth implementation in mental health, alcohol, and other drug services. And so each of these are answering a slightly different question, but the DCE is that consistent tool that's used across all of them. If you are interested in any of those projects and want to know more, then you can get in contact with us as well. And so I'm going to finish up there and open up to questions.
Thank you, Laura. There is one question in the chat. for yourself and Francesco. I'm happy to read it out. It's quite long, but I'll read it out for everyone in case they haven't been able to see it in the chat. In general, do you find many participants want to put together their own choice dimensions? For example, do you get comments that the choices are not agreeable? Who gets to put the options together? Is it the data from asking what matters from participants, or is it any of it researcher obligated?
Okay, that's a good one. I'll go first, Laura, or you want to go first?
No, you can go, Francesco.
Are you sure? Okay. So no, I was typing my answer. I didn't know that it was an interactive Q&A, but so I think this gives us the opportunity to have a chat on this point. So basically, the qualitative process that precedes the construction of the survey, whether you want to call it discrete choice, best for scaling, or multi-criteria decision analysis, really depends on the focus and the sort of level of stakeholders you're dealing with. So these are interchangeable terms often, but the reality of this is that the first phase, the qualitative phase, whether it's live or review based, is really to identify and map what matters, right? So focus group is a good vehicle to do that. Obviously, in that exercise, there are going to be discussions about what ultimately gets filtered. So there are very filtered to make it or make the cut for the instrument, which let's assume it's what Laura presented on vaccine hesitancy, which we're doing globally with or involving over 10 countries to really standardize. So to give you the dimension of this, so we did the qualitative work. We tried to understand what matters to people. And then the extra layer of this, we did it in many countries to kind of try and build an instrument that is standard across countries. So that decision obviously is done, I would say, in a mixed method, qualitative, quantitative approach. Sometimes that involves follow-up interviews with experts that tell you and comment on the attributes that you've chosen. In some other instances, you use sorting techniques that are more formal, that in a sense are kind of a discrete choice within a discrete choice, if you want. I hope that answered the question. Laura, if you want to add some things.
Yeah, I mean, I was just going to sort of more specifically answer some of the questions, like, do we find that people find the choices are not agreeable? That's definitely something that comes up in those pre-testing sort of development phases. And that's why we do that process, is to make sure that we're building a tool, building a choice set that answers the questions that are important from a research and a service perspective, but is also going to be agreeable to patients, and they're not going to sort of just protest vote and not do the survey. And yeah, I think Francesco has probably answered the rest of those bits.
Well, the follow-up, I don't know, I jump on it because it's a very good question. Is it ever politically driven? I suppose that, so we did this also with politicians. Actually, that was one of the first international projects. So we ran a multi-criteria decision analysis on big questions. So what on priority setting, whether in over 15 countries in Europe, China, Latin America, North America, and so on. Policymakers were given a discrete choice, in fact, to basically, according to 3 attributes for efficiency goals and 3 attributes for equity goals. And we wanted to observe how their fundamentally revealed preferences look like. And, to our surprise, there is quite a lot of consistency between what actually is expected in what you might think from a country, but quite a lot of inconsistency with actually the priority setting decisions that are made on the ground, which are very much ad hoc based. So when the political choice is made about offering a universal access to a service which costs X, there are very few variables that are considered. And if you actually propose a more complete set of variables, the choice looks quite different. And to make that connection, we actually then designed the packages, if you want, of services that would have come out if the actual politicians would have applied, their revealed preferences compared to what exists out there. So I encourage you to read those articles. You find them, I can send them to you. Just drop me an email, and you'll see there is a lot of interesting variation there.
Thanks, Francesco and Laura. I can see maybe, Laura, you've seen there's a few more questions in the chat. Are you happy just to take it from here?
Yep.
Yep, thanks.
Yeah, I just sort of smiled at that last question that came through, because I literally just came from a meeting before this where we were talking about using software like Qualtrics to conduct DCEs. Qualtrics is not ideal for conducting discrete choice experiments because the experimental construction of those choice tasks can be quite restrictive when you use something like Qualtrics, unless you pay for their like super premium version. But there are other surveys out there that do this a little bit better. So the new one that the uni is moving towards, Question Pro, has a whole thing that's specifically designed for building DCEs. RedCap's not bad. It sort of falls a bit in between the two of those. My personal preference is to use a custom built survey, but that requires quite a lot of programming expertise. But Qualtrics has been used to conduct discrete choice experiments by a number of people. There's a number of papers published on it, but you just have to change the way that you would do the design a little bit. And that's a whole nother field of research, is how you construct those designs. But yeah, happy to have a chat with you in more detail about software if you're interested.
Okay, are there any other questions or in the chat? If not, I will now thank you, Laura. Thanks for your presentation, and for yourself and Francesco responding to the chat questions. I'd now like to introduce Professor Balog, who is a...
You missed a question.
Oh, I missed one, did I? The bottom bit.
Okay, maybe I take that from Frank, I guess. Is that the one, John?
Yes, sorry. Yes, my mistake.
All right, so there seems to be an assumption that patient is able to give an informed statement about preference in spiritual care. Many patients receive and are highly appreciative of spiritual care, do not reside. Okay, so sorry, my screen jumped around. Do not realize this is what they have received. Asked to give their preference for this. How will they answer? Okay, so I suppose that I think what's important here, more generally speaking, it's that clearly that there are information problems in decision making, right? So nobody has access to full information. So even if so, that's one important point. And part of the exercise, also in the qualitative stage, is to assert that. So the patient's ability, or the practitioner or professional clinical access to knowledge, it's by definition bounded in terms of knowledge. There is a limit. Suppose that you change the approach and you think about doing a discrete choice that tries to elicit preferences of physicians. Certainly they might have an appreciation of what the decision maker sitting on top of them that decides the funding and has its own criteria and political agenda, perhaps, that access to that information is clearly not possible. So to obviate from this exact issue, which is pervasive in any choice that we make, so the access to information, the best solution is to run it at a multi-stakeholder level. that is the way in which we can understand whether there is a significant gap, measure it, and or find measures to overcome it and manage it. Now, that was the one that I saw.
Yep, I think that's it.
Okay, thank you.
Thank you, Francesco, and my apologies, Frank, for overlooking your question. So I'd now like to introduce Professor Jolt Balog. Jolt is the Director of Trauma Surgery at the John Hunter Hospital and also Professor of Surgery in the School of Medicine and Public Health at the uni. Welcome, Jolt.
Thank you very much, John, for having me here. And special thank to Francesco and Laura inviting to present here. I'm a clinician and trauma surgeon and trauma researcher. The way I come into this topic is we have this NHMRC funded project about the pretend trial, and you can see spelled out here. Basically, this trial is and funding is a collaboration between the University of Newcastle, University of Melbourne, and John Hunter Hospital and the St. Vincent Hospital in Melbourne. And I got a team of experts, and personally I bring for this project the clinical practicality of looking at surgery as a placebo and evaluate certain procedures, whether they're feasible to do this or not. My colleague, Professor Peter Chung, is leading it from Melbourne from the clinical research perspective. I can have the next slide, please. So the background is that there are very few randomized controlled trials in orthopedic surgery in general, but there are none in joint replacement surgery, which are actually would tell that joint replacement surgery is working, and it's a good alternative for other treatments. Joint replacement surgery, especially hip replacement surgery, considered to be the biggest breakthrough and one of the most efficient and cost-effective surgery in general, but there is no level 1 evidence to show that. And the recent study in the British Medical Journal, which was published just this July, actually lists, I think, 15 common elective orthopedic procedures from carpal tunnel release to lumbar disc surgery, which actually has no clinical evidence that they work. There are a limited number of sham surgery trials are available, and they tend to have conducted on minor orthopedic procedures like arthroscopy. And there are challenges in recruiting. So if you go to the trial registration website, there are many trials are registered, but they are very infrequently completed because of recruitment and enrollment related problems. So this collaboration aims the joint replacement surgery as a feasibility for a placebo surgery in a trial environment as a major surgical procedure. And our approach to this is to identify the conditions under which patients or surgeons would consider participating in such a trial. And the methodology is the discrete choice experiment, which I will talk a little bit more. So also we're aiming to estimate the cost and of conducting sham surgery trial for a major surgical intervention. Next one, please. So far, the group achieved whatever is on this slide. The two big reviews published, one of them in a top surgical journal. So clearly the surgical community is open to explore this. They just don't have the right information when these trials can be done. And the more practical part of this collaboration is currently just in a end of the data collection phase, when we collected data with this DCE methodology from surgeons and patients. So in short, this methodology means that it's a quantitative method which supposed to elicit preferences through hypothetical scenarios. So you'll see in the next few slides that we have scenarios which put to in a format of a survey to the patients and the clinicians to evaluate that what affects their choice and which is the situation when you would go ahead with this approach. So next slide, please. So this is the questionnaire for the patient. So that evaluates whether which study arm they would prefer to be, what magnitude or invasiveness of the procedure would be happy to take on, whether they would go for a trial for a total knee replacement, placebo, or an arthroscopic surgery only, what anesthetics they would happily go under for this, general or just regional, and just even nomenclature, that whether you like the phrase for sham or would use placebo. The scientific community tend to drift towards placebo, to use the same terminology which used in drug trials, and also evaluating the potential crossover in a trial design, and how many months after the index procedure people would consider crossover. And like any trial, what sort of follow-up, how many times they would be ready to be harassed by the researchers. Next slide, please. Quite with similar approach, we have a questionnaire designed for surgeons, and this is basically going through some of the aspects are same for the patient, but some of them are looking at specifics of the recruitment, whether a surgeon would prefer themselves consent a patient or recruit a patient, whether would like to have a study nurse, whether they want to be only a proceduralist or want to be actively involved in a design and the running of the trial and potential publication of them. Next slide, please. And just some very brief preliminary results from the surgeon's perspective. You see that we have fairly reasonable numbers, 169 surgeons participated in it. And I just want to make it clear that currently we are not doing any placebo surgery. This is all about optimizing the environment where it possibly could be performed to avoid dismal failures with lots of investment, which been around everywhere in the world. So generally, surgeons would prefer a less invasive and potentially more dubious procedure, like an arthroscopic procedure, which not necessarily established role, rather than much more invasive surgery and more expensive and higher risk, like a total knee replacement. Generally, they would prefer general anesthesia instead of regional, and most surgeons would say that they would like to have a extra arm in the studies where there is absolutely no surgery, neither sham or actual joint replacement or arthroscopy performed. And surgeons would prefer to be part of the study actively rather than just being a proceduralist. And they prefer to have a crossover around the year mark, and less likely to have a crossover before. But they wouldn't mind who presents the information to their patients, and as long as this is a robust ethics approved study and they inform what's going on, the actual mechanistic parts of the trial sounds like not the key hurdle in it. So that's pretty much it from me, and I'm happy to answer any further questions. And thanks very much for Laura providing the slides to me, which I just had to modify according to my message I wanted to deliver. Thank you very much.
Thank you, Zsolt. Now, happy to take questions either on the chat line, or if you wish to put there. I think no, I can't do that. The chat line is the preferred. There's 77 people. Any questions?
I think, Zsolt, are you departing this session now? Might be important to mention that to
Yeah,
any
I need to
participants.
go back to
if they have any
an on-call day, and I really appreciate that the time slot, and I'm lucky that I managed to sneak out.
We're really grateful that you could join us. So I guess if anyone has any specific questions for Zsolt, we have him probably for another minute or two. Otherwise, thanks, John. We'll be back over to you.
Happy to answer via email if you guys try to find me, and if I can't, I just forward it to Laura or Francesco.
Great. Well, thank you again, Zsolt, and enjoy the rest of your day. Thank you.
Thanks, everyone. Bye-bye.
Bye. So we've now got a video presentation from Dr. Nick Zenkowski. He's a medical oncologist at Hunter Valley Oncology and a conjoint senior lecturer at the School of Medicine Public Health at Newcastle Uni. Nick also is a former Hunter New England Clinical Research Fellow. So it's good to see Nick's coming back up to share with us what he's learned and what he's doing in terms of his clinical oncology research. Casey, are you sharing the video with us?
Sure am. Yep. So fingers crossed. You should be able to hear this sound.
Thank you for the opportunity to speak about my experience with discrete choice experiments and the clinical relevance. These are my disclosures. So discrete choice experiments measure the trade-off between options. And I'm going to talk about the example of my Travel for Trials study, which was looking at how willing patients are to travel to participate in a clinical trial, specifically thinking about different treatment options. And so we know that trials for specific situations are available in centres, but not everywhere. And we ask ourselves, should we refer them elsewhere, either within or outside the region? And here we took the dependent variable of whether a patient would participate in a trial or not, and then presented them with some hypothetical situations with variables, including increasing travel time, change in oncologist or oncology centre, the type of trial, and reimbursement of costs. And with those number of variables, we estimated that 20 observations per scenario were needed and 10 participants per scenario, and a total of 192 participants. So we presented them with a hypothetical scenario. Would you join a trial if you were presented with a certain situation? All of the participants who we included had been diagnosed with cancer, and they answered an online or paper-based survey. And it was a short stem and made it clear that this was a hypothetical situation, and then asked them to tick a box as to whether they would be willing to participate in a clinical trial in that given scenario. There was a brief explanation about the clinical trial option, but not a lot of detail because a lot of clinical trials are very different. But we wanted to make it clear that there was an additional time and additional effort that was required, and it was an unproven medication. So it was a medical oncology trial. And here is a mock-up of the different options, and this is including all of the options. However, when they were put into the survey, there was a range of different scenarios that included one of each of these boxes, and they were then given 10 with different variables, creating a different hypothetical scenario. And then at the bottom, there was a question about whether they would join or whether they would have the usual treatment. So
Have we lost sound?
Yes.
the results are that most patients are willing to travel to participate in some circumstances. We had 256 respondents, 26 chose don't join for every scenario, and 45 chose join for every scenario. So therefore, just under 90% would join a trial if the situation is right for them. But as we increased the travel time, the participation intent dropped to less than 50%. If changing oncologist was needed, then 57% would not participate. We did logistic regression analysis, which allows us to show how much of a change if one or the other variable were changed. And 20.23 would increase their intention to join if there was no change in oncologist. But interestingly, the type of trial, whether it was a blinded or open label randomized controlled trial or a single arm trial, did not alter preferences, which may have been a lack of understanding. Then there was a willingness to pay threshold, which in our analysis showed that patients would be willing to travel as their payment an additional 121 minutes to avoid changing oncologists. Now we've moved into a current project, which is about to start, which is about patients' priorities after a diagnosis of low-risk thyroid cancer. The options being surgery to whole or part of the thyroid versus observation with a variety of variables. And this is aiming to develop a patient decision. Thinking about the design considerations, firstly, is discrete choice experiment suitable? It allows comparisons between variables using a numeric variable, often cost. Consider the audience's health and general literacy. Writing the stem for the scenarios is key for these hypothetical situations, and make sure that the variables are presented in a very comprehensible format. And then explaining the results is the next challenge, whether that be to reviewers, readers, lay people, or people who are writing guidelines about how to manage these situations, whether it be with policy or patients or clinicians. Thanks for your attention, and happy to respond to any questions, or please send me an email.
Thank you, Nick. Thank you. We'll convey our thanks to him. So,
John, I'm actually online.
Oh, sorry,
so
Nick.
Welcome. I'm available for some questions.
Okay, over to you. Over to people to ask Nick some questions.
All quiet on the chat at the moment.
Hi, Nick. John again. I've got a question. How
Yeah.
do you, and maybe also Laura and Francesco could think of this. So the purpose of a DC, or in this case, the DCE, is to ask patient preferences. And how does that, the results of such a study, how are they considered in a decision-making progress from a health system or health clinical decision point of view? Because they're beyond the patient, there are other factors that need to be considered, like the feasibility, the availability of resources, the cost of a particular treatment option, for example, and the economic and the financial implications of different choices. So have you gone so far as to say, well, here are the results of what the patients have indicated, and then had to come up with some sort of decision-making process to, in a sense, balance each of those different elements of decision-making and to make a choice? How would you go about doing that?
Yeah. I mean, it's a good point, John. So one of the key aspects of high-quality healthcare is acknowledged as patient-centered decision-making. And so keeping the patients at the center of those decisions, but you can't say that that's the sole way of making healthcare decisions, because you've got patients who will make, they prioritize their own health conditions, of course, and there are a range of other priorities from a policy perspective. You've got to cover the gamut of health conditions, and there are some health conditions that may not be as well represented by patients, and where you need to take into account the burden of disease and the potential for gain, and in producing healthcare policy, and so the intersection in patient-centered decision-making with then going on to developing guidelines based on evidence or expert opinion, and the potential costs of any intervention that might be considered, takes I guess a lot of discussion and an overview, and I'm not sure what the best way of doing that is. Like, I don't think I can answer how everybody can be considered to have an appropriately weighted opinion on how policy and guidelines can be produced across different specialties. So when you're within oncology, sure, we can have that discussion and have a reasonable understanding of it. But in if you're thinking about oncology versus cardiology, or what do you prioritize? I don't know how to answer that. I'd be interested in how other people think about it.
Thank you, Nick. So I want to throw that to Francesco.
Yeah, well, I guess to Nick, there is a very short answer. That's why you need economists, right? But you need to try to trust them in using these instruments. I think what's interesting from Nick's presentation is clearly how you can bring this to a very, I would say, service level dimension, right? So the priority setting decision, because it is what is done, what Zolt is doing on the feasibility of a trial on sham surgery, right? Whether it's feasible, are we gonna ever hit the number of patients that we need? So that is basically a funding decision in the hand of an economist. So that is useful for us to understand ex ante, the feasibility of things, right? So it is a priority setting question. Clearly, everybody's very sort of focused on the importance of each areas of expertise and so on. But what a policymaker does when he's allocating resources, and I've seen this in practice, he does this or she does this, I would say, in what we refer to ad hoc manner. So the contribution, so it's not providing like a normative approach, right? So it's providing a positive way to look at what these wastes are among the different factors that come into play in a priority setting element. But it's obvious that you know, the interesting exercise is the one that comes after. So once you have the weights in front of you, you have to decide, okay, an extra $1 for oncology versus cardiology or whatever Nick was referring to. In that moment, what you need to do is to understand really the impact of that decision, which is not necessarily captured in this piece of work. The follow-up piece of work that is needed to occur, it's what we did, for example, in this high-level priority setting discrete choice experiment. And we use those weights and we actually go and build what the actual delivery of healthcare services globally looks like if we base the health service delivery on the outcomes of the discrete choice experiment. And then with that in front and what it exists, then you have to make another assessment and a trade-off and then decide, because that's the ultimate trade-off. So that's why we speak as economists a lot about multi-level, multi-stakeholder approach. So this journey, I think it's a long one indeed. I think it's worthwhile because we can learn from these let's say multi-steps towards the you know, ultimate decision on what to fund, what to service, how, and so on. But I would call it pretty much it's important to do it to be able to understand if you want and contribute to the implementation side of things. Without that bit, I think Nick is quite right. It remains, you know, an exercise very valuable that informs the decision makers, but we need to do that extra step at the end and really look at this and evaluate what would be the services out there and what they are, and that is the real decision with all the attributes and outcomes and benefits and costs incorporated in that experience. And it is done. I mean, it is done in some occasions, and I would say that ad hoc decision making is becoming less attractive, also because the public has a very reactive approach to decision, and media plays a large role. And you've seen this during the pandemic. So you know, our decision makers are very sensitive to things. So I hope I answered that. It's a very beautiful, complex question. So thanks.
Thanks, Francesco. So Casey, there's a few questions on the chat.
Yeah, I think Laura had offered to respond to the question. Thanks, Laura, on the PBAC. Yep, PBAC. Yep, thank you.
Yeah, also happy to answer those other two questions that have come up around kind of health literacy. But I'll jump on the PBAC one first. Yes, question asker, you are correct that the Pharmaceutical Benefit Advisory Committee currently doesn't place a huge amount of importance on things like discrete choice experiments and patient experience. Their guidelines, well, at least the 2015 guidelines sort of explicitly mentioned that any studies using outcomes should be underweighted compared to studies looking at cost effectiveness purely. But Australia seems to be a bit behind the ball on this in the international space. So in the past, just couple of years specifically, there's been a really big push from a lot of the European HTA reimbursement agencies to more explicitly include preference-based measures. Standard gamble and time trade-off are the most commonly used ones, which are a bit more sort of down the economics route. But there's been quite a few papers pushing to include things like discrete choice experiments. The main reason that this hasn't occurred up until yet is kind of because of some of those advantages of DCEs, because they're quite flexible and can be quite tailored. It does make it a bit harder to include any sort of guideline about how they should, must be included in any of these processes. So there is a bit of a push in this community, this preference solicitation community, to be able to have a bit more of a standardized way that they can be included in these reimbursement and regulatory decision-making bodies. Should I just jump on to the next question? So there's also been a couple of questions coming through about how do we deal with people that have troubles understanding difficult concept or have low health literacy. Basically, this all comes down to really thinking about this when you're designing your discrete choice experiment. So like Nick mentioned it a little bit in his, that you have to have a really clear vignette. You have to really think about if your questions are sort of sensible for the people that you're asking them. And you might have also noticed that in a couple of the DCEs that myself and Zolt presented, we had pictures. So there's another whole area of research around testing and making sure under what settings people can and can't understand discrete choice experiments, and pictures are one of the things that's been shown to improve health literacy. A lot of this research comes from lower income countries. There's quite a lot of research in a lot of the African nations regarding sort of decisions for HIV and a lot of the sort of maternal health questions that we just take for granted here, but they're trying to design their health system, and a lot of the community that they're interviewing and using discrete choice experiments on don't have the same level of health literacy that we have here in higher income countries. And so there is a lot of work in this space in trying to ensure that discrete choice experiments are understood by everybody. And when you're designing one, you need to think of that, and you need to read this literature and ensure that you include those factors. That's a great question. Thank you.
Yeah, so I would like to make a point here. I mean, I don't think it's a first, second, third world issue. This by no means.
That's just where the literature is.
Yeah,
Majority.
I think that when you design this, and I think the best example, I think it's the hesitancy. So the one that we're doing, and I think it's a good reference, because the way in which these pictures are conceived typically come from very educated people. So without doing what Laura said, and understanding the mindset, it can create a significant bias. So Laura made a very good point in referring to that. But the socioeconomics of Australia in terms of health literacy or literacy is very different from the one of any other country. So we have really I think we have really to spend quite a bit of time, especially if we want to standardize the tool across different regions, communities, and even more so countries. And that in itself poses some challenges. Yeah, on the PBAC, I think Laura made a very good point. I think one of the issues that I see compared to the HCA's framework, frameworks that are in action elsewhere, is that they're somewhat more prescriptive. In a sense, you have a threshold approach. Sometimes NICE is an example. So there is a pretty clear framework in which you can embed and construct additional criteria to classic cost effectiveness approaches that might lead to the adoption of DCs. Clearly, our approach, in my mind at least, or the way I would refer to, is more sort of a pluralistic in a sense, right? So there are different skill sets and disciplinary contribution to the ultimate decision of whether or not to subsidize something. And well, and then there is COVID, and I bring it always as an example, because both in PBAC and AMSAC, I have to say that in this period of time, decisions have been made very fast to include or exclude or change the funding. If you think of telehealth, for example, services, even reimbursement changes to some of the medical benefit schedule and the pharma-based ones. I think that is a clear example on how fast decision making can happen without necessarily considering what's basically in front of you. nothing else of what's in front of you. So deal with the emergency. So I think that is a good example of priority setting in itself, if you want. Obviously, these frameworks are complex to embed in a formal framework, but it's happening. And again, it's an additional information tool to come to a more or let's say a less ad hoc decision making process.
Thanks, Francesco. Any other questions, chat?
We've just had another question come through from Frank. Frank, do you feel comfortable turning on your mic to pose your question? Or
thank you. I noticed that it's easy to talk about research and that within what you might call the clinical space. In the softer spaces where we're talking about the human interaction and the clinical benefit through that. And I'm a chaplain, and just a little bit of background about me. I've been a chaplain for nearly 4 decades, and I'm also a trainer of chaplains through the Sydney College of Divinity at master's level. And I observe that, as in my first question, that many of my students talk about what they do at the bedside, and we use a bedside learning model, experience very positive responses from patients who don't realise they're actually receiving pastoral spiritual care. And even when they've received it and we go away, they would not be able to answer a question about that. I guess I'm struggling with understanding how to generate research in that space, and I struggle to understand the mindset of researchers within the health space, which seems to focus only on clinical, hands-on surgery, that kind of thing. Is there a way of expanding the vision? Because the evidence that I'm aware of is that our pastoral care, and that's where my area is, pastoral care provides a $1.6 return for every dollar spent. It shortens, good quality pastoral care will shorten a stay by 1.25 days for many patients. So we are financially viable, but not considered. And the research says that it's because there's a fear that funding for clinical stuff will be taken away if we send it to the softer spaces, but the softer spaces don't attract the research. So we can't actually demonstrate the evidence within a health context or something that is acceptable to the health context. Any comment there?
I think I'll jump in here. That model of care that you're describing, Frank, reminds me a bit of the sort of movement that's happening within the psychological support space, where to declinicalize care and involve more peer support groups and online communities, and that sort of approach. And I mean, just talking specifically about discrete choice experiments, there are papers out there that look at comparing these different types of scenarios and these different types of settings of delivering care and ways of delivering care to people. And when you're doing it with a discrete choice experiment, for example, you don't have to explicitly tell people, you know, would you prefer pastoral care versus clinical care? You can create 2 different scenarios which comprise, you know, features that you would experience in pastoral care and you experience in clinical care, and you're getting people to decide between which scenario they prefer. You're indirectly getting information about those features that are important to people. And that might be one way of getting around that kind of sort of effect that you're seeing, where people might not be explicitly able to say, you know, this specific type of care is what I prefer, but this feature is something that I appreciate or I found helpful.
Thanks, Laura.
John, I'm going to have to step back to clinic if that's all right.
Thank
But
you
thanks for the opportunity to present and to be part of this.
Great. Thank you very much, Nick. Take care. Okay. I don't see, tell me, but I don't see any additional questions.
No, we had that extra comment in the chat, which was for Frank. Just someone offering some ideas there. But I think we've covered off all of the chat and we're within time of the session. John, did you have any closing remarks today?
Yes, I'll just again thank all the speakers. I think this is a very important area, as I sought to introduce at the beginning, that the way we consider our healthcare and our health system choices, resource allocation and way of engaging with patients and consumers can be influenced by a variety of different factors. And as a number of people have mentioned, presenters have mentioned, that historically there has not been sufficient focus on patient-centeredness in our care delivery. And I think this particular form of research and value-based healthcare, which incorporates the patient's perspective, is a significant advance forward in our research and in the ability of health services to make appropriate decisions. I think that's why I think it's very important to bring this to the table for all researchers to consider a broader range of perspectives, and particularly the consumer perspective. We can also take the term consumer or patient-centered and also look at it from the perspective of the healthcare providers. And so there's other research which Laura's engaged in, and Francesco, where the DCE approach or the preference solicitation approach is being used to identify what caregivers or clinicians prefer to be appropriate models of care or appropriate or beneficial ways to support their delivery of guideline recommended care. So I think the application of DCE approaches, analytical approaches more broadly, has got a lot to add almost every aspect of the research in terms of improving healthcare delivery and hence patient outcomes. So I'll just thank everyone again for bringing this new area of work to the table and for challenging us to some degree. Some of the questions I think are quite important in terms of having a deep understanding not just of the process of the values and the principles of value-based healthcare and the processes of this particular form of research, but also how it then subsequently informs decision making. So that could be a topic for another day. So thanks everyone for participating. I'd like to thank all of the people who came online. I think it was in the order of 80 plus people. I think that's a fantastic turnout given the significant disruption that we're all facing in our work lives and our home lives. So thank you everybody. Thanks to the presenters and take care.